world. He's more than just a man who wrote the story of hope. Jesus is the Savior of this world. Jesus is the Savior of this world.
Thank you very much, Sister Jones. Jesus indeed is the healer of
Yes.
this world, healer of all our challenges. So we should have this Zoom link up. We should also have those who wish to go on YouTube. Uh, Sister Audrey Brown should be monitoring that. So we have shared screens this afternoon. Hope that we will be blessed. At this time, I am going to be introducing Sister Nollet Green Ashfall, who is our Human Resources Officer at the Northeast Jamaica Conference. She was instrumental in getting our presenter this evening, and she is working in tandem with the Women's Ministries Department so that we become educated. We want to thank you, Sister Ashfall, for this
Yes.
effort. And now we ask that you will go ahead and introduce our presenter. Thank you.
Are you hearing me?
No, we're not.
All right, let me try again. You're hearing me now?
I am hearing you loud and clear now. Go ahead, please.
Okay, good evening. Thank you very much. Good evening, everyone. It is my pleasure, my delight to join with you this evening. And it's my pleasure to introduce to you our esteemed special guest this evening, Dr. Trevor Brian Potter. I've had the pleasure of knowing Dr. Potter for just a few months, and I can testify to the work of this noble gentleman, very humble, but a very, very good doctor with gifted hands. And so let me take a minute just to give you a little background on who the man is. Dr. Trevor Potter is a University of the West Indies trained generalist, obstetrician, and gynecologist. He has been in public and private practice for over 20 years. He led the OBGYN team at the Maypen Hospital before becoming the senior medical officer at the Port Antonio Hospital. Currently, he dedicates his professional time overseeing 3 offices in Kingston, Maypen, and Port Antonio. Although he's a generalist, OBGYN, he has performed many different types of surgical procedures related to his field, his sub-interest is in reproductive endocrinology, infertility, and vaginal surgeries. He had extensive vaginal surgery training in New South Wales, Australia. This has allowed him and his team to perform more vaginal hysterectomies than any other medical institution in Jamaica year after year. He has developed and mastered the technique for intramyometrial, doc, do not hold that one against me, injection of a modified clean solution during myoectomy procedures, which is a removal of fibroids, allowing for minimal intra-op blood loss, low post-op pains, sores, leading to less post-op use of narcotic pain medication, quick return to a normal diet, usually after 4 hours post-op, early hospital discharge, and a rapid post-op recovery. Dr. Potter takes pleasure in working where others play. He is an active member of the International Society of Cosmogynecologists, ISCG, and as a cosmetal gynecologist, Dr. Potter delights in applying his talent and skills in restoring the anatomy and function of the female lower genital tract. He gets a joy and a sense of satisfaction in hearing his clients' exuberant glee in having the functional anatomy of their lower genital tract restored. For those ladies who leak urine when they laugh, cough, or sneeze, his simple in-office technique of using biologist para-uterally and intravaginally to restore urinary continence and vaginal wetness in postmenopausal women. It is his love, interest for reproductive endocrinology that has allowed him to easily pivot his practice to address the challenges and needs of the maturing adults, both female and male. He was trained extensively in the United States of America to administer and manage bioidentical hormone supplementation to the symptomatic maturing female menopause and male andropause. He loves to teach and has two international publications. One, the mercury concentration in the placentas and paranutrients at the University Hospital of the West Indies and its correlation to known risk factors during pregnancy. And two, vasopressin versus normal saline as hemostatic aid to dissection at vaginal hysterectomy. Number three, when Dr. Potter is not with family, he spends his spare time hiking and biking. That's a mouthful. So you've heard about the professional side of Dr. Potter, giving you a little bit of a background. But if I should take another second or two to just share with you that my experience, my personal experience with Dr. Potter, having been diagnosed with endometriosis a few years ago, and in November was told that I will have to go through surgery. Now, after getting several opinions, I decided that, okay, I'm ready to do the surgery. Went in, I was recommended to Dr. Potter, or Dr. Potter was recommended to me when I decided to do my surgery at the Andrews Memorial Hospital. And I can tell you that Dr. Potter is not just for the surgery, but it's for the whole person. He tries to make sure that his patient, and I'm testifying now, is very comfortable. He explains everything. He doesn't hold back. He doesn't make you feel as though he's rushing you out of his office. And so when I went in for the surgery and ended up having to do another surgery, which was, we could not help it. So I ended up doing two major surgery. The support and the type of treatment I get from Dr. Potter as an outpatient after being discharged from the hospital is second to none. I can testify after going to several different doctors, I can say that Dr. Potter was the best one that I ever came across, and I would recommend him fully. And so this evening, it is my esteemed pleasure to welcome you to the Northeast and to all the viewers on our platform, Dr. Potter, those both in the Northeast and from the wider Jamaica Union and even beyond. And I hope this evening you'll enjoy yourself being here with us and that we will learn a lot from your presentation as we look forward to it. Welcome, Dr. Potter.
Thank you very much, Lady Ashfall. That's advertisement. I already see persons asking for the office number, etc. And I know it's going to be even better as Doctor gets on. Thank you very much, Doctor, for sharing with us. You may go ahead.
Thank you, Mrs. Ashford. Jamaicans have a saying that my head get big. With all that kind word that you're saying about me, my head is really swelling at this moment. But thanks, anyways. Let me see how I do this now. Share my screen.
Well, your screen is being shared as we speak. Maybe you could just start the slideshow now.
Slideshow.
Yes. Here you go.
All right. Ask this evening to present on the differences of condition actually. Fibroids and endometriosis. These are conditions that actually affect women in a particular way, right? And sometimes they are very confusing in the way in which they present. So I'm going to take the time this evening because I'm asked to present the differences between fibroids the signs and symptoms, diagnosis, and treatment options that we have a lot to present, so I'm going to try and move very quickly because I want at the end of the presentation that there is interaction in terms of, well, you can ask me these kinds of questions, straight, real, as it goes, right? So in order to present this, I'm actually going to give you a kind of background as to what this is about. Now, fibroids and endometriosis, they are a part of what we call the pelvic pain syndrome. They cause pelvic pain, bottom line, pelvic pain, right? And that's what most women will complain, will come to you about it. I have belly button pain, I have this that is bothering me, I have that is bothering me. So it's a part of the pelvic pain syndrome. Now, if we look at the pelvic pain syndrome, we see that looking at the anatomy of the pelvis, that anything in itself in the pelvis can cause pelvic pain. We look and see, for instance, bowel can give rise to pelvic pain. Bladder can give rise to. Here we have the uterus that can give rise to pelvic pain. Fallopian tubes, the ovaries, they can give rise to pelvic pain. And even this covering right here that covers the pelvic organs called the peritoneum can give rise to pain. And deep to these structures as well, they have things like blood vessels and nerves can give rise to pelvic pain. Don't forget as well, bone, muscle, the pelvic pain. All of these things can give rise to pelvic pain. But in our presentation, we're going to be looking at uterine fibroids and endometriosis to see if there are any differences. If, as a doctor, I can make a distinction between, oh, is it uterine fibroid or is it endometriosis? So let us go and see if we can make a distinction between both of them. And yes, they are two distinct conditions, and the distinction is between their pathological basis primarily. When we look at fibroids, for instance, we see that fibroids mostly affect the uterus, right? And this organ here, the uterus, which has a main function of gestation, that is carrying the baby, as well as expulsion of the content or the products of conception, the fetus, the placenta, and the membranes at an appropriate time. So that's a function of the uterus. But looking histologically at the uterus, we see that the uterus here is actually here from the body of the uterus and includes the cervix. It does not include these appendages, the fallopian tube, nor the ovary. So we don't consider these part of the uterus, but they're appendages. But when we look at histological in the uterus, we find that the uterus consists of three layers. One, the peritoneum, which is commonly referred to as this serosa, the myometrium, which is the muscular layer where the strength of the uterus comes from. This is where all that strength that comes in when it's time to expel the fetus during vaginal delivery. And the inner portion right here, which is referred to as the endometrium, which we'll talk about a little bit more when we start discussing endometriosis. And this we know is where the menstrual flow comes from. So the uterus again, in histological basis, the perimetrium, the outside, the myometrium, the muscular layer, and the endometrium. Now, what are fibroids exactly? Technically speaking, fibroids are referred to as leiomyoma, or in the singular, and plural is leiomyomata if you're from the UK, or leiomyomas if you're from the US. Or for short, it's actually myoma or myomata or myomas. So that's a technical form, but we all call them growth and call them all kind of different things, right? Now, fibroids genetically or histologically each fibroid is derived from a special muscle cell. This is an example of a muscle cell. It's called a smooth muscle cell. Now, there is an abnormality, a chromosomal abnormality that develops within the smooth muscle cell that causes it to have a proliferation. Now, it is important that this proliferation, for the most part, is benign, right? Not going to be cancerous for the most part. Not that fibroids aren't cancerous, but there's a small percentage of fibroid, 0.001% of fibroid that are cancerous. But for the most part, fibroids are benign proliferation of the fibrous tissue associated with this single muscle cell. And the gross appearance is that it looks like a firm, hard, spherical mass or growth. That's the reason why we call it growth at time. But it's important to recognize that fibroids can develop in any organ system that has smooth muscles. Here we see on the upper left-hand side, this is a bowel, right? Bowel has smooth muscles as part of its architecture. And here is a fibroid that has developed in the bowel. right? We also have stomach, which can give rise to fibroid, and blood vessels. But majority of fibroids we see actually develop from are developed in the uterus. So they're called uterine fibroids, right? And again, I mentioned that the fibroids that develop from the myometrium, this area, this is where all fibroids develop from, right? So they may develop from the myometrium and actually they may grow outward. As you can see, this fiber is called a subserosal fiber because it's growing outward and it is actually causing an indentation or a deformity on the outer surface. Here's a large fibroid develop in the fundal area. It's a subserosal fibroid. And then fibroids can also develop and grow outward and become pedunculated, that they're actually living off or I should say, directed away from the uterus. You also have fibroids that can actually lose their connection with the uterus and they become parasitic and they're living on the intestines itself, on the external the intestine. Here we have some other fibroids. This fibroid is called a pedunculated submucosal fibroid. This is the fibroid we generally refer to as the bleeding fibroid. This also is also a submucosal fibroid that give problem. Fibroids can also develop in the cervix as well. Now, here's an example, clinical example of a uterus that has lots of fibroids inside. You can see the fibroids, this distorting the shape of the uterus. Here we have a subserosal fibroid. Here we have subserosal fibroid. This is the fundus, and these are several large fibroids that are developing. Now, the question, million-dollar question is, what causes fibroid? And to be honest with you, I don't know, and I don't think anybody knows what causes fibroid. What we do know is that there is a genetic insult, chromosomal problem. Either the chromosome, there's a deletion of a chromosome or a gene, there is translocation, transmutation, or something that goes wrong with the chromosome. What causes that to happen? We don't know. But what we do know is that there are predisposing factors. People who are going to develop fibroids have a predisposing factors. And the greatest and strongest predisposing factor is genetic. We know that if we have somebody ancestral that has fibroids, chances are it's going to be, I will also have fibroid because of the genetic reasons. Why this happens, we don't know. The other strong related or risk factor, predisposing factor, is race and ethnicity. We do know that people from so-called Africa or the Afro-ethnic individuals have a high predilection for fibroids. Why this occurs, we don't know. Another thing that we do know is that the Africans, for instance, Afro-Caribbean tend to have even greater predilection for fibroids compared to, say, for the Afro-Americans and other Afro groups themselves. Why this happens, we don't know. Predisposing factor also include hormone imbalance. Fibroids has a tendency to increase estrogen receptors so that people with fibroid tend to have higher serum concentration of estrogen, particularly estradiol. And also growth factors such as insulin growth factors. These individuals have a predilection to developing fibroids. Also, the extracellular matrix tend to increase in individuals who have a risk or increased risk factor for developing fibroids. The extracellular matrix is that matrix, that substance that keeps two cells together. And people who have an increase in this amount of substance between their cells will develop fibroids or increase risk of developing fibroids. We also know that lifestyle changes or lifestyle behaviors also predisposes individuals to developing fibroids. One such thing is obesity. And my theory is that obesity leads to estrogen dominance because there is a hormone that is present within your fat tissue that actually converts testosterone to estrogen. So there is a tendency for estrogen dominance in people who are obese. Now, a diet rich in red meat also predisposes to fiber. Note that the literature doesn't say a diet rich in chicken, as we all blame best Caribbean, the producers out here who produce chicken, that, well, I'm not going to eat any more chicken because it's going to cause fibroid. Literature actually points to red meat and not necessarily chicken. Diet that is low in vitamin D also predisposes to development of uterine fibroid. Another condition that causes fibroid is stress. Belief is that stress increases your cortisol level. So you become hypercortisol, and this in itself produces obesity. And we already mentioned what obesity does, that it increases estrogen dominance, right? So that is the relationship here. A study recently shows that a history of childhood trauma and abuse also in individuals who will get fibroids, there's a predilection or a predisposition for developing fibroids in these individuals. Well, I think this mechanism is through stress, and I mentioned again, stress causes obesity, obesity causes estrogen dominance. Other factors that predisposes to fibroid is age. We know that people in their fourth decade or in their sixth decade are more likely to develop fibroids. Yes, it can occur in individuals in their third decade, for instance, individuals in their 20s also will develop fibroid. Another important factor is parity. Parity is how many children or how many births or term births that is given. When I was growing up in medical school, they always say that if fetus does not occupy the uterus, then a fibroid will. That usually was so-called a mantra. So people with low parity, having no children or spaced out children, tend to get fibroids more than those who have five children quickly or have more children. Early menarche, that is the age at which you start your period. These individuals, the earlier you are, the more likely for you to develop fibroids. Again, this mechanism is through estrogen, because you start your period earlier, you are exposed to the sex hormones that are there, right? Now, let's look at endometriosis and look at the pathological basis of endometriosis. Now, endometriosis is a benign condition that exists when biologically and hormonally active endometrium, which we already said that what is deposited in sites other than the endometrial cavity. Now, here, these red dots actually show the endometrium, which is here, being deposited in other areas on the bowel, between the space between the bowel and the uterus, right here between the vagina and the bowel. Here we have it in the bladder. Here we have it in the peritoneum. So here we have it on the tube. Here we have it. So any area where we have endometrium being deposited other than where it's supposed to be, this condition is termed endometriosis. Mark you, these deposits must be biologically and hormonally active. Again, here we have endometrium being deposited in the muscles of the anterior abdominal wall here, which we'll show you a little bit of later. Now, here is an example of the endometriotic deposits being deposited all over the pelvis. And it's important to realize here, this is the ovary on the right-hand side with endometrium inside there, forming what we call an endometrial cyst, or generally speaking, we call it an endometrioma, right? Now, again, what causes endometriosis? Don't know. But what we do know is that there are some theories that actually will say what endometriosis is, or why we have endometriosis. The most acceptable theory is what we call retrograde menstruation. What is that? For the most part, we're aware that this is the endometrial cavity. The menstrual flow actually comes from here, and it comes anterograde through the cervix, out the vagina, and then into the environment. That's where the menstrual flow occurs. But there are individuals in which the menstrual flow actually will flow in a retrograde fashion through the fallopian tubes and into the pelvic cavity itself. Now, this menstrual blood may contain active or living cells from the endometrium, and these cells will form fertile, as it were, ground to actually develop into active endometrium external to the endometrial cavity. As a consequence, these active or living endometrial tissue will respond to the hormones of pregnancy, hormone of the sex hormones. And in so doing, on a cyclical basis, month after month after month, you will have the bleeding that occurs here within the cavity, whichever space they are found in, and give rise to the condition of endometriosis. Right? We'll talk about that a little bit more. Now, genetic predisposition is one such factor. We know that patients or people who have ancestors with endometriosis are also predisposed to getting endometriosis. Immune factor. This plays an important role because literally or practically everybody has retrograde menstrual flow. So why is it that some individuals will get endometriosis and others don't? And we believe that it is dysfunction in the immune system that actually causes this to occur. Your immune system is unable to extricate or to get rid of the endometriotic deposit once they occur. And that is the situation. Again, hormone imbalance. For instance, estrogen dominance, another key. We saw that happening with fibroid, that estrogen dominance play an important role. Endometriosis causes an upregulation of the estrogen receptors. So these individuals tend to have higher serum levels of estrogen as well. Now is an important concept. During embryonic or fetal development, what we call coelomic spread of stem cells. We know stem cells are cells that actually have pluripotential. They can go into any tissue or differentiate into any tissue that they want. Now, a cell that is supposed to be an endometrial cell, when it is supposed to go to the endometrium, make a wrong turn somewhere, probably at Albuquerque or whatever, and ended up, for instance, in different areas, for instance, in the lung, the brain, or somewhere else. Now, this condition actually, or this theory actually explains why endometriosis can also occur in male. Yes, endometriosis can occur in male as well, but it's very, very, very rare. It explains why endometriosis occurs in the lung or in the brain, or even so, why endometriosis is occurring in this young lady's umbilicus, in her navel, right? So this is what happens. We think it's a coelomic theory that we're stem cells that are destined for the endometrial cavity end up in another place and develop into endometriosis. Now, endometriosis can also be caused iatrogenically, I call it. I mean, us doctors probably cause it, particularly during pelvic surgery and specifically during cesarean delivery. When we're delivering the baby, endometrial tissue on our hands or somewhere, we're pulling it through the abdomen, for instance, and as we close the surgical wound, this tissue deposit in the scar itself. So we end up getting scar endometriosis. Here's somebody with a bikini cut right here, and you see on the right-hand side of the scar, an endometrioma that develops. Every month, this young lady will have swelling pain in this particular area. And on the right-hand side, similar sort of situation, this person from there too. Cesarean delivery, you can see two scars here, get the endometrium on this side here. Now, pathological basis of endometriosis is scar. That is what causes it. Scar formation, or what we call cyaniki, within tissue or between tissues. Now, this scarring that occurs in endometriosis is what is the basis for the clinical syndrome. So you get tissue or organ dysfunction as a result of this scarring that occurs. We saw this diagram before. Here we have endometrial tissue. You get the bleeding that occurs every month, month after month. And I mentioned the menstrual flow can egress through here, normal menstrual flow, but that which is in the ectopic sites do not go anywhere, but they just stay there. And month after month, they end up on the heel, what we call chronic inflammation, set up a chronic inflammation, and they heal and create scars. So you may have scars being formed between the uterus here and the ovary, between the ovary and the fallopian tube. And you see scarring all over. One of the fundamental thing about a scar is a scar has this habit of contracting, right? So a scar loves to pull things. So it will pull the tube out of its alignment or out of its normal anatomical structure. Now, you can imagine a condition, for instance, if you have deep endometriosis, all this scarring occurring deep beside nerve tissue, beside blood vessel, what the sort of things you're going to have. For instance, main consequence of this scarring is pain because you're having distortion of organs, you may have nerve involvement, and you may have other things that create pain as well. Now, here is a virtual picture of what endometriosis has done. Look at all this scarring that is occurring. There is an obliteration of the space between, this is the uterus here, and right here is bowel, right? This is a very important space right here. It's called the pouch of Douglas or the posterior cul-de-sac. Infertility, that space is obliterated. So this person has infertility, cannot become pregnant naturally. Look at the right tube. This right tube here If you were to look at the left tube right here, it looks kind of normal. I'm not so sure if it is normal though, because I can't see the end of it. But look at the right tube. It is distended and it's almost in a ball, right? Like a balloon. It's balloon. So this tube right here is no good. So this person here is definitely infertile. Now, before going any further, it would be remiss of me not to mention another condition, which is somewhat related to endometriosis and sometimes cannot be distinguished as well as fibroid, and it's called adenomyosis. Adenomyosis is like endometriosis, I call it their cousins, but depends on where they are. No, it is endometriotic deposits the within the muscular layer, which is the myometrium of the uterus. So it's endometriosis actually within the uterus itself. So this is adenomyosis. Um, and this is a clinical example of what adenomyosis is. You see this almost looking like gristle tissue, um, just like that, right? Now, you or someone you know may suffer from chronic pelvic pain. So the condition is that how can you tell if the pain that you're suffering from is caused by fibroids, endometriosis, and as I mentioned, adenomyosis? Sometimes there is clinical ambiguity. It's hard to tell which is which. Is it fibroid? It is adenomyosis. Is it endometriosis? It's really hard to tell, right? Because patients may have both uterine fibroids and endometriosis, or they may have all three concurrently: fibroids, endometriosis, and adenomyosis occurring together. So it's really hard to tell which they have. Now, in order to do this, though, it's best to do our clinicals. One, patient should undergo physical examination. Important, right? That's important. Then do pelvic ultrasound, which is probably the cheaper of the two, 2D pelvic ultrasound. Pelvic CT scan, not so sensitive, but can be done as well. Uh, Magnetic resonance imaging, probably the best to use, but it's quite expensive, right? Now, this is an example of an MRI picture showing a large fibroid, fundal fibroid, actually pushing up. You can see pushing up on the diaphragm, the stomach on here. Here's the liver on this side here, and there are endometriotic deposits. Sorry, fibroids along the way here. The uterus is distorted, very much so. Now, clinical disambiguity, to clinically disambiguate the imaging, we should actually um, each patient should actually undergo physical examination, as I mentioned before, do the pelvic ultrasound, pelvic computed tomography, or MRI. But the gold standard, actually, if you want to make a distinction between fibroids and endometriosis, is to do like diagnostic laparoscopy. Now, diagnostic laparoscopy involves um, using a laparoscope, which is actually a camera, which is inserted through a major port, usually through the umbilicus. And then you have a grasper where we look around. The stomach is filled with some gas, usually carbon dioxide. And this procedure is done under general anesthesia. So you can imagine costs associated with doing this procedure. But this is the gold standard because it is able to determine what the patient has, particularly if they're presented with endometriosis and you're unable to tell. Now, in terms of imaging accessibility, we mentioned that pelvic ultrasound is probably ubiquitous. The 2D doesn't cost as much compared to even 3D, but 3D is unaccessible. It's good, but the problem with that, apart from the cost, is that not many doctors are able to do a 3D pelvic ultrasound. So it's not widely available here in Jamaica. The computed tomography or CT costs some money, not very sensitive, low sensitivity in picking up fibroids. Magnetic resonance imaging is good at picking up fibroids, telling you exactly where they are, but it costs. An MRI may run you somewhere up to $100,000 for a pelvic MRI. Diagnostic laparoscopy, dollar signs like crazy because you're dealing with a surgical procedure. Very sensitive equipment, very expensive equipment to maintain. You're dealing with an anesthesiologist, you're dealing with a theater, you're dealing with a nursing assistant, and you may deal with an assistant. So all those things are costs. So this sort of thing is often out of the reach of most patients in terms of making the diagnosis of, say, the difference between endometriosis and fibroid. But the best, as I mentioned to you before, is to use pelvic ultrasound, 2D. So how do we clinically disambiguate the pain of uterine fibroids, endometriosis, or adenomyosis? Can we use the pain quality to do this? And if we were to look, for instance, on the onset of the pain, duration of the pain, cyclicity of the pain, and the intensity of the pain, these quality of the pain may not be helpful because the onset of the pain, for instance, may be the same with, with fibroids, adenomyosis, or endometriosis. It starts just before the period, or it's there before the period, and it goes on through the period. Duration of the pain may be the same. Cyclicity means in terms of every month you get the same pain, it worsens during a period. The intensity may just be the same. So the pain quality is not a good way of determining or distinguishing, is it endometriosis? Is it fibroids or adenomyosis? So what I normally do is actually look for associated symptoms. What are the symptoms associated with these conditions that I can use to distinguish endometriosis from adenomyosis? You know, endometriosis, yes, may affect different organs in the pelvis. Right here, we see on the ovary, so you may get ovarian cysts, it may affect the bladder, may affect the bowel. So depending on all the other symptoms associated with the pain, I can use these to distinguish what we're getting. We also know that endometriosis can be superficial. So the effect may be a superficial effect in terms of the pain, may not be as far-fetched, or you may not have an issue, or maybe deep. For instance, you may have endometriosis here is the colon, and you have endometriosis infiltrated into the colon. Here you have endometriosis, as I mentioned, into that space, the pouch of Douglas right here. You have endometriosis here in this ovary, so you get an ovarian cyst. You have endometriosis infiltrated into the bladder, into the bladder right here, and then you have endometriosis actually penetrating deep into the peritoneum, into in the retroperitoneum, creating havoc with this fallopian tube right here, the one on the right. Now, fibroids, the pain of fibroids tend to be a little different. Fibroids tend to create pressure associated in their association with other organs. So they tend to create pressure, pain, a sense of a mass, or to some extent. Now, here is a fibroid uterus causing uterine or urinary symptoms. What they normally do, I say cause pressure. So this is the sort of thing that fibroids will do. This weighted uterus, this fibroid here, resting directly on the bladder. So you have this sensation that your bladder is full. Go on pee, but it is full still. In the nighttime, I wake up 6 to 10 times a night to pee, and I'm just peeing a little bit of pee. Right? This is called nocturia. So normally a woman is either 0 to 2 times per night. She may get up 6 or 10 times for the night. So you get this sensation all the time. So this is what fibroid does. It gives a sensation, load, pressure on the bladder, right? So you get this other sensation with fibroids. When it comes to endometriosis, how do we separate them? Here is endometriosis infiltrating into the bladder. So this endometriotic tissue going into the bladder, going into the musculature of the bladder, what it does is that it causes irritation of this musculature. So you get what we call the overactive bladder syndrome. I've got to go, got to go, got to go. You have the sensation that you're going, and it goes going frequently, right? The other thing that is associated with this going frequently, you get a thing called dysuria. That is painful urination. When you pass urine, it hurts because the muscles are now have scar tissue in them, because remember I mentioned that scarring, here we have scarring with endometriosis. So the urinary symptoms of endometriosis, you get the gotta go syndrome, you get dysuria, and the other one that you may get as well is hematuria. Fibroids don't do that. Fibroids, remember, cause pressure. Pee a lot, always feel full. Pressure inside there. This may cause hematuria, blood in the urine. So that's the difference. Let's look at what it does to the bowel. Here's a fibroid resting on the sigmoid colon. It's pressing against it, right? So what may happen from this? You get occasional constipation. So you get your constipation going on here. Occasional constipation, you go and you pass in goat type do, those little round ball or pellets you pass now and again, right? And you have difficulty there. That's most of what you're going to get with fibroids causing bowel symptoms. Here we have a situation with endometriosis creating a problem. You may get what we call partial or complete bowel obstruction, have difficulty passing stool. Yes, you get the constipation, but you'll also may get a thing called obstipation, where you're not passing gas. So that's a different thing. Here you have endometriosis in the sigmoid colon. What you're going to get with this? Endometriosis infiltrating the wall of the bowel. So what you're going to get? You're going to get dyschezia, painful defecation. So you're going to do, and it's going to be painful defecation. And if with this endometriotic deposit here, you may get hematochezia. You're passing your stool may be black, or it may be you may see bright red blood inside it. For instance, here, this endometriotic deposit, as the stool comes down, it irritates it, and you get blood from your anus. It's called hematochezia. So those are the sort of things that will happen in terms of distinguishing clinically. So the associated symptoms that you're going to get, yes, they may cause the pain and everything else, but urinary symptoms is kind of different. Bowel symptoms kind of different for endometriosis as opposed to fibroid. Now, here are some symptoms that we can use to separate and say, oh, fibroids does this, endometriosis does this, right? Fibroids, what fibroids does? Fibroids may cause an increase in the abdominal girth, or the size of your abdomen becomes big. You may feel a mass or something. Endometriosis, unlikely to create this. You may not feel a mass unless obviously you have what we call that endometrial cyst, or that endometrium, a large endometrium, and you may feel something, or may feel a pressure, pelvic pressure. With fibroids, it's unlikely for you to get it again unless you have that endometrial cyst. Uh, with endometriosis, with fibroids, you can get leg edema, for instance. If you have large fibroids resting on your leg veins, you may have poor return of blood to the heart. So you may get swelling of the legs occasionally. It's unlikely to occur in endometriosis unless you have deep endometriosis that's infiltrating behind the peritoneum and actually creating vascular problems. Limb neuropathy, for instance, some women will have, oh, my period is going to come and I get a sharp pain. I get a pain extending into my legs or something like that. That is common in fibroids. It's less likely with endometriosis unless, again, if you have deep endometriosis affecting the nerves in the peritoneum. With lower limb, fibroids may cause lower limb DVT, that is deep venous thrombosis, and the consequence of that is pulmonary thromboembolism. It's less likely with endometriosis because, again, if you have deep endometriosis affecting the blood vessels in the retroperitoneum, then that may occur. Fibroids is likely to cause pregnancy complications. For instance, you may have miscarriages, early miscarriages. You may have situations where preterm labor. You may have low birth weight infants. You may have babies that are born with what do you call it, contracted deformity, because they're competing with the space with the fibroid. Endometriosis, once you become pregnant, is unlikely to create those sort of issues. Now, fibroids and endometriosis will create, for instance, dysmenorrhea, that is painful menstruation. Yes, they both do. They can cause menorrhagia, that is heavy menstrual flow. Yes, they both do. May cause metrorrhagia. This is prolonged periods. Yes, they can both do it. Intermenstrual bleeding between periods. Yes, they both can cause these conditions. Postcoital bleeding, that is bleeding after sexual intercourse. Fibroids are likely to do that, most particularly if you have a fibroid within the cavity, an intracavitary fibroid or a submucosal fibroid. You're likely to get postcoital bleeding, or a fibroid that has collapsed through the cervix. Endometriosis, less likely, you're not going to get that. Dyspareunia, this is painful sexual intercourse. Yes, they both can cause dyspareunia, particularly endometriosis. Now, the HSSD, which is hypoactive sexual desire or female sexual dysfunction. Yes, what is that? Because of pain, particularly because of dyspareunia, there may be an antipathy or what we call an aversion to wanting to have sex. So women may develop these issues that they do not want to have sexual intercourse because of the pains associated with having fibroids or endometriosis. Now, they both can cause depression because anybody who suffers from chronic pelvic pain becomes disfiguring. Every month is the same thing over and over, and there seems to be no help. So they may become depressed over a period of time. Fatigue, yes, I'm tired of this. I'm really and truly tired. They both can cause fatigue. We know fibroids can cause anemia because of heavy menstrual bleeding. So too can endometriosis. And importantly, they can cause socioeconomic disruption. Yes, economically, I'm constantly going to the doctor. I have to spend so much money for imaging studies. I have to spend this and spend that and whatever. I'm missing from work. So there's economic dysfunction. There's also socioeconomic things. I'm not interested in sexual intercourse so much anymore. My young gentleman, my husband, not really understanding what is going on. So you may have socioeconomic disruptions from this. Of course, they both may cause infertility. Endometriosis more so than fibroids. For instance, we saw this picture before. Here we talked about the pouch of Douglas being obliterated. Very important space when it comes to becoming pregnant. If this space does not exist, it's hardly likely that you can become pregnant. And again, here, because of the adhesions, the end of this tube became blocked up. So endometriosis create infertility here. Here we have both tubes are obliterated at the ends, and you have what we call hydrosalpine Gs. Both tubes are occluded. They'll almost look like a snail shell. This is the end of one tube going around like this and come around. The other one is like this. So both of these tubes are no good. They have to be taken out of this lady's continent. Here is, pardon me?
Jackie Edwards, can you mute your
All right.
mic? Sorry,
So,
dog.
all right, sorry. So here's one. Somebody did a HSG, hysterosalpingogram, and both tubes are actually distorted. You can see the ends are blocked up. And this tube is tortuous because of endometriosis. And here is what fibroids can do, right? Here is a situation. Here's the tube going right here, the right fallopian tube. Here is this fibroid here blocking the area where the tube, you have access, the sperm has access to get into the tube to become good to the peritoneum to actually find that egg to fertilize. Here's another situation on the left-hand side. Look at the position of this fibroid right here. Look what it has done. It has distorted the interstitial portion of the fallopian tube, and it probably has even narrowed the caliber of the tube and make it such that a sperm, if these weren't here, a spermatozoa can actually come in here, get to the tube, pass the tube, get to the egg, fertilize the egg. The fertilized egg tries to come back in here, cannot pass this here, and what you end up getting? An ectopic pregnancy, right? Now, here's a situation. Here's a situation. Here you have a prolapsed cervical fibroid. No sperm can actually pass this here and get over to get inside here. Here you have submucosal fiber that's distorted. Here you have a situation that the endometrial cavity is occupied by an intracavitary fibroid. So you see here fibroids can cause infertility. Now, the important thing in making the diagnosis is actually listening to the patient. Take a key medical history. And in my case, I told you, make an association or find the associated symptoms to find what's causing the pain. How's the pain going? What is it associated with? Then you do a clinical examination and obviously the appropriate investigation. Well, laboratory tests, they're non-diagnostic because they're not helpful, but they're not necessarily helpful in making the diagnosis, but they're helpful in terms of, for instance, are you anemic? We can do a complete blood count. Do you have any kidney problem because fibroids resting on your kidney or the tubes that are carrying urine from the kidney to the bladder? That, so we do those laboratory tests. But the key thing here is to do our diagnostic imaging. Pelvic ultrasound, 2D is quite ubiquitous. The CT scan, I should probably take this up because it has very low sensitivity. Magnetic resonance imaging, much better. Diagnostic laparoscopy, wow, costly. Other axillary tests that we want to do, for instance, we want to do sigmoidal colonoscopy. I showed you where that you can have fibroid actually or endometriosis getting into the bowel, so that's important. And then we have, for instance, we may need to do a cystoscopy because we are having hematuria to see if endometriosis has actually gotten into the bladder, or we may do a cystourethropy to look for anything, for instance, endometriosis actually occluding the urethra, the ureters, or even fibroid resting on the urethra creating urinary problems. So how do we go about treatment? And the treatment options. It's always multidisciplinary. I mentioned to you, for instance, maybe associated with depression because of the chronic pelvic pain. So it's best to consider getting psychologists on board or some counsel on board to offer some degree of counseling with regards to depression that the lady may have and help her, for instance, overcome some of these issues. We also may include, for instance, an interventional radiologist. I'll tell you about this later. An endoscopist or a gastroenterologist. We saw where fibroids or endometriosis may be in the bowel or We may get even a urologist because we see where it may even be in the bladder to do a cystoscopy. And generally speaking, we may use a general or laparoscopic surgeon as part and parcel of the team to help us with certain things. There are other things that may occur. For instance, we may need a hematologist to help us with to amend things like anemia, or may need an internist to help us to deal with some, for instance, kidney failure of some sort, or to that extent. So it's a multidisciplinary approach. But importantly, in the management of these two conditions, two things are important. One, age of the patient and the patient's desire to continue their reproductive capacity. Those are important considerations. Let me say it. Then what is also important, the extent of the disease process, how much it is, how much is present, and the impact on the quality of life, that is the QOL. Have this thing, how is it affecting me? It's affecting me socio-economically, it's affecting me psychologically. What can I do? How can I do my treatment so that my quality of life will improve? Now, the gold standard of treatment of endometriosis, I don't care what anybody want to say, the gold standard of treatment is surgical. It is there, remove it. That is how it is done, remove. So it is a surgical process. I don't see any medical way. I don't know of any herbs or anything that can actually treat it, but it's a surgical management. Now, the surgical treatment of endometriosis actually can be surgical ablation, either you use in terms of burning it. We can either use laser energy, or we can use what we call radio frequency. Common thing that we use to just burn it. We see we go in, we see it, and we burn it, right? Or better yet, we see it, we can excise it, we take it out, and that is how we deal with it. Now, it is important that the surgical approach is best done laparoscopically, because as I mentioned before, endometriosis is associated with scarring. General surgery, laparotomy surgery, oftentimes is associated with scarring. We know when we do laparoscopic surgery, the post-operative scarring is minimal. So it's best to do operative laparoscopy if we're doing for endometriosis, right? Now, medications, I said, have non-definitive and temporizing rules, or maybe adjuvant to surgery. For instance, you did an endometriotic surgery, you don't see, because endometriosis can be tricky. You may see some of the deposits, and some of them are crystal white, you can't see them. You're not good enough. All you see sometimes is a little scratch in the peritoneum. The peritoneum is that silvery shine surface that covers our bowel. And all you see is a little scratch. You may not even see it. Like a little, you have a little silverware and you use steel wool on it. That's the sort of appearance that you may get from it. So that medication may help you at that point in time to help to starve the endometriotic deposit of its estrogen or other things. So the gonadotropin releasing hormone or the luteinizing hormone releasing agonists or antagonists, we know them as either Leucrin or Lectrum, are the drugs of choice. These drugs, if anybody have ever used them, know that they have significant side effects. They immediately convert you to the menopause, and you start experiencing hot flashes, headaches, insomnia, weight gain, leg joint pains. You get the whole work, but they're able to reduce your sex hormones and actually starve the endometriotic deposits of their nutrients. The oral contraceptive tablets and Depo-Provera or herbal treatments do not eliminate endometriotic lesions, because once you stop using these, then there is reactivation. So it's just a temporizing effect, and then you have to deal with the side effects associated with these hormonal therapy. So I mentioned before that the treatment of endometriosis is usually minimally invasive, so you want to do it laparoscopically, but there are times when laparotomy, open surgery, is advised, right? So you may go in laparotomy, open surgery, to do pelvic adhesiolysis, that is to break down the scarring, because remember I said that with endometriosis, there's tons of scars associated with it. Sometimes you may end up doing hysterectomy and castration, that is removal of ovaries. So you starve the endometrial deposit of the ovarian, impact for estrogens. Now, sometimes as well, you may go in and there's deep endometriosis into bowel, so you need to do bowel resections and reanastomosis in some instances. Sometimes there's a need to do the tube, the ureter that carries urine from the bladder carries urine from the kidney to the bladder, is embedded in them in endometriosis. So you may sometimes we will have to actually divert the urine from the obstructed area. And so you need to splint and reanastomose the ureters. So you need a urologist on board. So the treatment of adenomyosis deposits, they're proposing that, well, you can go in and actually excise the deposits, but I think that is an effort in futility because what will happen is that there's a high rate of recurrence. For me, I think this is a bowl, a kidney bowl or kidney dish containing adenomyotic tissue that was excised, but this patient that I did many years ago, she now has a recurrence of her adenomyosis, right? So for me, I think once you're finished, having children and whatever, the best step forward with adenomyosis actually to do a hysterectomy. Now, when we look at the treatment for uterine fibroids, again, the approach is multifactorial, right? Many things must be considered. Again, the age of the patient and the desire to continue their reproductive career. The thing with fibroids is that we can start off, well, we can do what we call expectant management, where we do exactly nothing. Because there are some women with fibroids have no symptoms whatsoever. There's no pain, no pressure, no menorrhagia, no infertility, no disparring, and nothing at all. So in these ladies, you obviously will not go in, even when you pick up a fibroid incidental on ultrasound. She is having no symptoms whatsoever. You know, many times I go cesarean delivery, I'll find fibroids on the outside of the uterus. They're having no symptoms. Leave it alone, right? Now, medical is the other method, medical conservative, medical medication that slows the growth of fibroids. For instance, I mentioned them before, the GnRH and the LHRH, agonist and antagonist. Again, I mentioned they have significant side effects. And usually once you take them off, then, they come back. They used to have this sort of drug, they call them sperm, actually is, what do you call it, selective progesterone receptor modulator sperm. And these drugs, they were touted to actually, they can shrink fibroids, and the drug companies were out selling them like crazy. And they had to pull it from the market because they're actually causing hepatotoxicity, and several patients actually die from the use of these drugs. So they're not no further on the market. So medications are not necessarily important. I know some people are going to say, I know somebody who used this or used that, and the fibroid shrunk. Maybe so. I don't know. I can't say for sure. Right? So the treatment of fibroid I mentioned, they can be expectant. You do nothing. Medical conservative, when you're buying time. For instance, you may be buying time to deal with some symptoms. The patient is in the transition to the menopause, because when the menopause hits, then you're going to get a situation where the fibroids may shrink and you may not have the menorrhagia associated with this. But the definitive treatment for fibroid is actually is surgical. Again, not because I'm a surgeon, but the important thing. Something there bother you, cut it off. It may be conservative or it may be invasive, the type of surgery that we're going to do for fibroids. A conservative surgical treatment for uterine fibroids, radiological. Let's look at this. We mentioned an interventional radiologist. This is called uterine artery embolization. This technique is where we take advantage of a blood vessel and we form a clot in a blood vessel. So here is the uterine artery that supplies the uterus. And obviously the uterus, the fibroid is getting its blood supply from this. So if we starve the fibroid of its nutrients, then this fibroid, anything that is starved eventually will die from lack of nutrients. So this is the attempt. So we get an interventional radiologist who actually cannulates your femoral artery in your legs and deliver these particles, these embolic particles into the uterine artery and actually causes what we call necrosis or infarction of this. Painful procedure in terms of because once any tissue that is dying will create pain. There are issues with this because you can have misembolization and these particles go to the ovaries and actually cause the ovaries to die. They can embolize and go other places. So this has to be done in an expert arm. There are few people in Jamaica, I think it's probably one person I know in Jamaica that actually does this, uterine artery embolization to deal with fibroid from this perspective. Now, the other method is to use high intensity focused ultrasound, call it HIFU. Now, if you look at this setup, obviously, this has dollar signs written all over it. It's a technique that requires ultrasound, high intensity ultrasound, right? Obviously, this is not available in Jamaica, but I'm just saying it here because it's available, where we use either ultrasound guided techniques to find the fibroids, and what we call myelizing. We apply heat energy, significant heat energy to the ultrasound. We find the fibroids through ultrasound, and we pass the ultrasound, high frequency ultrasound, to that destroy what we call myelization of the fibroid. We can do the same thing with MRI as well. So it's MRI guided. So we know exactly where the fibroid is, and we pinpoint where the fibroid is, and we focus the fibroid like a laser beam right on the ultrasound on that fibroid. So this is MRGFUS, magnetic resonance guided focus ultrasound. So these two techniques are not available in Jamaica. So before I go any further, I'm going to issue a little bit of warning here that the following slides may contain contents that may be disturbing to some, so viewer discretion is advised. Right? So when we look at our conservative surgical treatment for fibroids, we're looking at myomectomy. Myomectomy is a procedure where there is preservation of the uterus, right? And the patient's fertility prospect. I think that should be the reason why we do myomectomy. Some patients may request a myomectomy because they just don't want the uterus to come out at all, because if the uterus comes out, then I'm not going to feel like a woman. Remind me to say more about that later. All right. So we have the main thing is laparotomy, where we do open surgery. The open surgery, we make an incision, so-called bikini cut. Technical name is span and steel incision, or may do a midline incision. The midline incision may be below the navel, or it may extend up depending on the size uterus that you may have, right? So vertical incision. So the essence of a myomectomy, we go in, get the uterus, or the principle rather, we make an incision, and we make an incision in the uterus, and we enucleate, go into the cavity where the fibroid is, and we enucleate. Take the fibroid out, take the fibroid out, take the fibroid out. Up the spaces, close up the spaces, close up the spaces. So this is the principle of doing a myomectomy. There's a little bit more to it. Here's a patient that we operated on, probably the largest fibroid I've ever done in my career. It actually extended. You see where this person have their hands. You see right up there under the xiphisternum, right under the rib cage. This fibroid here. Believe it or not, this person wanted a myomectomy. Most people would have probably done a midline incision. Skilled enough, I was able to do a fan and steel incision. Here, we're looking at it, this is before the surgery, and here is after surgery. You can see significant deflation of the abdomen through a nice fan and steel incision. And I want you to look at around the bedding and tell me what you see later on. We'll talk about it. All right. Now, open laparotomy, again, this is the same patient right here. We talked about, Miss Ashford Green talked about something in my bio about using a special fluid. Here I am injecting my modified fine solution, my secret solution, into the uterus or around the uterus. And what it does, if you notice the uterus right here, it's pale, that there's pallor. So there's now, what it does is that it shuts off the amount of blood flowing into this. Here's a blood vessel here, large blood vessel here. We want to make sure that there's hardly any bleeding coming from doing this fibroid. Huge fibroid, huge fibroid. Right, so we put in the solution inside there. Here, we have taken the fibroid out. You see, I have to use both hands. A big, is a basin or kidney dish, whatever it is, but we have a big thing. Looking around, this is it in the disc. If you look at it, it's still pale, hardly any blood inside here. So the blood vessels are have hardly any flow inside of them. So here, the solution worked very well, right? So open surgery. Here at the end, the whole deal of doing a myomectomy is preservation of the uterus and fertility prospect. Here, the surgery was done. Look around. There's hardly any blood on the sheet to suggest that, wow, we got away with it, right? The incision was a wide incision. Here is the uterus. As the principle say, we enucleate, take the fibroid out and repair. There's no bleeding happening. It is still pale. Hardly any blood is flowing here at this point in time, right? Nice. All right, so we do open laparotomy. Important when we do fibroid surgery, because as I mentioned to you, when you do laparotomy, you increase the risk of scarring, right? So you want to preserve fertility as well. So we use this thing called an adhesive barrier, which we actually put down once we have done the surgery, cover the uterus up and cover the scar where we put it down so that there is no scarring or minimize the amount of scarring that occurs. So it's important. Anybody who's going to do myomectomy and don't use this anti-adhesive barrier, then it's best not to do the procedure. Now, all of my patients who do myomectomy, do surgery, because the lady you saw earlier on, that procedure, she is awake do the procedure. And this is what we normally do. We do our spinal anesthesia. Here's a patient preparing, the anesthesiologist preparing to apply the anesthetic. It's a perfect position. This lady is in a C-shape convecture and opening the space so the anesthetist can actually apply the spinal anesthesia. Works like a charm. It has many benefits over general anesthesia. Tons and tons of benefits. Allows you to recover, allows you to eat faster, allows you to get up and move around, reduces the risk of DVT. It is a super, it reduces, did I say, blood loss. Now, the other thing that we can do for myomectomy is so-called the conservative method, minimally invasive laparoscopic. Here we have laparoscopic surgery, show you the main port and three other ports. Here's a setup right here, doing um, laparoscopic myomectomy. I must tell you though that this is a procedure. I do not advise this in our population, simply because our population has a different set of fibers in terms of we don't tend to have one fibroid. Here you see, this is good to take off this fibroid right here. Perfect. One digga fibroid, as the word may say. And you can do laparoscopic surgery. This is best for probably Caucasians or say the Asians, but not necessarily for us Afrocentric individuals, simply because our fibroids, they come as a group. They come together. Look at this. This is from one patient. You have this big fibroid here, some others. But look at these all small fibroids. These are fibroids the laparoscope cannot see. When I do, and I used to teach when I used to teach to do surgery, I usually tell my residents that, look, fibroid surgery is not what you see, it's what you feel. Because once you can't see, you have to feel. There's no way you can see these fibroids. You have to feel for them and you feel the tissue. The laparoscope is not able to do that. So it's best not to do laparoscopic surgery in Afro ethnic individuals. If you're going to do it, then make sure you have an MRI and you can pinpoint and say, oh, they don't have any of this. Because if you were to do laparoscopic surgery in an individual like this, it's like you take this out. Well, guess what? It's like you're in a forest. You cut down the main tree, and beneath the main tree are many saplings or seedlings. Once main tree is gone, what's going to happen? These are going to grow. So you're going in another few months or so, this patient is going to represent with you or come back or record to you with the similar symptoms, and you would have wasted that patient's. So it's best, even though it's laparotomy, to go in and do surgeries like this, because sometimes, which is in what my case as well, I always enter the cavity to feel for fibroids that are present. Now, here's another method of doing fibroid. Say, for instance, you have one single submucosal fibroid that is just there. You did your MRI, you did your studies, and you say, it's one little fibroid that's causing the bleeding problem. And you can access this fibroid through what we call a hysteroscope. So you do hysteroscopic resection. So this may be a little tricky thing because it only works for fibroids that are what we call FIGO 0, FIGO 1, or FIGO 2. That is fibroids that are in the cavity, you can see them, and you can actually loop and take them out. Or you can pare this off, gently pare it off, resect it. But if you have the fibroid, this portion of the fibroid that is in this portion of the fibroid that is in the myometrium, it's hard to get it because what's going to end up happening is that you're going to now start paring the myometrium. And what will happen? You may end up perforating or bursting through, thin this wall so much that you burst through. And what is right behind there? The bowel. You go right into bowel and you create problems. So it's probably sometimes best not to do hysteroscopic resection, or it's best to do hysteroscopic resection if and only if you're dealing with a FIGO type 2, that majority of the fibroid is hanging out in the endometrial cavity. So that is another method of doing it. So we're going to come now and speak about the main thing, a hysterectomy. That is removal of the uterus. I mentioned before, the uterus involves the body and the cervix. So that is the uterus. That is the uterus in total. Now, there are types of hysterectomies. These are things that people usually confuse and say, oh, I did a partial hysterectomy or I did this. Because one, they think a partial hysterectomy involves only taking out the uterus, and they confuse it at times. Well, when I do a total hysterectomy, it involves taking out the fallopian tubes and the ovary. No, that's not it. A total hysterectomy involves just taking out the uterus and the cervix. So that's a total hysterectomy. A hysterectomy has nothing to do with the taking out the adnexal tissues, for instance, the fallopian tubes or the ovary. It only has to do with taking out the the body of the uterus. So it goes down here, take the body and leave the fallopian tubes and the ovary inside too. Here is another type of hysterectomy. We call it the subtotal or partial, as you may call it. This is a partial hysterectomy. Here, the green part is removed and the cervix remains inside, right? So we have the cervix inside there going on still. This I really don't appreciate. I see younger surgeons are doing it now. I don't know what studies they have. The reason why I don't like this thing here, because you're leaving an organ inside here that actually has a potential to become cancerous. We know about cervical cancer, the potential to become cancerous. And what is the benefit of the cervix, really and truly? Outside of, for instance, gestation, to hold the baby inside there. Some may think that, well, it offers me sexual pleasure or whatever. But think about it from a sexual perspective. Sorry, you guys are the Christian, but let's be real. In terms of sexual pleasure, less than 1% of women will achieve an orgasm from cervical stimulation. So if we're speaking to you in the interview and I say, okay, we're booking for hysterectomy, I'm going to do a total hysterectomy. I'm not leaving it. And you say to me, oh, doc, the only time I get an orgasm is if my partner stimulates my cervix. That's the only time I get it. Well, I can say, okay, you're there. But generally speaking, I am not going to leave the cervix in this patient. One, I'm predisposing it in the future. If this cervix becomes malignant or becomes a problem, then I'm predisposing to another surgery. Plus, I'm predisposing it to continue to do pap smears. I know most men don't like doing pap smears. So if I leave the cervix in, you have to do your pap smear. If I do the surgery and everything is okay, that's the end of pap smear for you for the rest of your life. You don't have to do another pap smear, right? So that's the reason why I tend to want to do a total hysterectomy. Yes, there are situations when I will do a partial hysterectomy. And this usually is in the case of malignancy. For instance, I'm dealing with a malignancy of the ovary, and then you have a thing called ascites, and the weight of the water actually pushes down on the cervix, and the cervix keeps the vagina inside so you don't have a prolapse. So that's one of the ways I will leave it, and that's probably the only way that I will leave it inside. Otherwise, I will go ahead. Now, so we're talking about minimally invasive procedure and the laparoscopic assisted vaginal hysterectomy that we can do this as well. We do a hysterectomy minimally invasive using laparoscopic technique, and we can use laparoscopic assisted vaginal hysterectomy. Now, vaginal hysterectomy, Ms. Aswell mentioned in my bio that, yes, I did a lot of vaginal surgery. I was in Australia for a little bit, and I learned to do a lot of vaginal surgery, and I probably enjoyed doing a lot of vaginal surgery, particularly vaginal hysterectomy. And I'll give you a choice because it offers you a quicker recovery than, say, abdominal, because you have no scars to deal with a vaginal hysterectomy. And if I can get it out vaginally, I will get it vaginally, because you're up and about moving around. Most of the time, people will see you, oh, I didn't know you had surgery. I thought you had surgery. No, you can't tell with these sort of individuals. So vaginal surgery is not something that is out of my portfolio. It is there. No, sorry for this picture here. Here is an individual who had an elderly lady who had uterine prolapse. So this is our uterus here prolapsing through the vagina. Also, our bladder has come down. You can see the bladder right here as well. So this is a lady that has what we call procedentia, or type 3 uterine prolapse. Everything is out. So vaginal surgery is best done on patients like this. Now, what are some of the consequences of a hysterectomy? We find that the main consequence of a hysterectomy is that there is going to be a cessation of menstrual flow. Now, technically speaking, this is what is called your menopause. Most of the time when we talk about menopause, it's not menopause, it actually is. We associate menopause with hot flashes X, Y, and Z, can't sleep, miserable, all these kind of things are menopause. That's not menopause. Menopause is an event in this particular part of our life. When we talk about those symptoms, we actually talk about the climacteric, but everybody calls all that thing menopause. But just for the correction, it's actually the climacteric that we're going through, right? So when we have a hysterectomy, we get cessation of the menstrual flow. So we get surgical menopause, okay? And there is also confusion that a hysterectomy is associated with female sexual dysfunction. And you may have either culturally or otherwise, some men do not, do not like their women when they hear that their women going to have a hysterectomy. Whoa, that's the end of my sex life. Because guess what's going to happen now? You're going to take this uterus out, right? And all that there's going to be, here's the vagina here. There's no uterus right here. And all that there's going to be, there's this empty space right here. So my penis is not going to find anything up here. And it's just have this abscess, this big old space here. And that's a myth. That's not true. That's not true whatsoever. As a matter of fact, let me tell you what happens. Once you take, most surgeons, once they take the uterus out, if they're going to do a total hysterectomy, take all of this out here, they will close the top of the vagina here. Most surgeons do that. And then they'll anchor it to the pelvic side walls to prevent future prolapse of the vagina, the apex of the vagina through the vagina. So they will do that. I, for one, do not close the vagina at the top, or I'll partially close it and leave part of it open, right? So yes, I'll leave it open, but I'll leave it open for a purpose. Sometimes after surgery, there may be a collection of blood or whatever it is inside it, for whatever reason. You may have a little collection of blood. Now, if I leave it open, that blood can actually drain out through the opening and out the vagina. Now, if I were to close it off at the time of surgery, what happens is that that blood stays inside there. When that blood stays inside there, for some reason or the other, it can become infected because once you open the vagina, sometimes you allow microorganisms to enter into the pelvic or into the pelvis, and this can infect any blood or anything that is collected inside here. Now, if this were to happen, for instance, end up with an infected collection, then it means that, guess what? I have to go back into surgery, open this lady to drain that collection. Makes sense for me, I think, that I leave a part of the vagina open, allow any postoperative fluid to drain out so that we don't get any problems afterwards. Because here's what happens. Our good God, in about 2 weeks, closes off the opening anyways, whether I leave it open or closed. So why not leave it open? Because you have a lot of surgical benefit instead of closing. But going back to the myth that men have, there is no abscess that is created by doing a hysterectomy here. And then the ladies believe, oh, my sex life going to mash up because I take out the cervix. No, less than 1% of women will have orgasm because of that. 90% of women will have an orgasm because of the crew of the clitoris down here. So another important thing is that the healing process, once the vagina heals, it heals in a apex. So you have an apex. So the apex is narrower at the top than it is at the base. So you find that the vagina at the top is narrower, actually. It has this narrow sort of thing compared to when it was like this. So it's now like this, right? So the whole myth associated with sexual dysfunction after hysterectomy is a myth as it is. The other thing, remember, some women have dyspareunia because of the fibroids, painful sexual intercourse. Fibroids were creating the problem. I can't have sex anyways because I'm bleeding, always bleeding. I have intercourse, I have pain. So I don't enjoy what I'm doing or whatever. So I don't have it. So I have an antipathy to sex, an aversion to sex. So it doesn't happen. So hysterectomy itself may be the cure for that. There are many patients that I've had who have had hysterectomy now are saying, oh, I'm enjoying my sex life much better. So the quality of life is now better from a sexual perspective. So that is where we are, right? How long does it take to recover from a A hysterectomy. Normally, I guess in my hand, I don't want to pat myself on the back because of my special solution. I use my special solution in practically everything I do. I use less narcotic analgesia. The patient don't require narcotic analgesia. They are usually, most of my patients are actually discharged on the next day. That patient that you saw with that huge fibroid, minimal blood loss, she was discharged the next day. My patients, for instance, I will do a patient on a Saturday, discharge them on a Sunday, and by the Monday I see them. And oftentimes when you come to my office and you see a patient, you can't tell, did that patient have a surgery? My main office is on the second floor, and there are no elevators leading to that office. So the patient has to ascend the steps. And many times, no issue. 2 or 3 days afterwards, they go home, no problems because of special solution. So it doesn't take long to recover. But generally speaking, though, I normally give 6 weeks post-operatively to recover. But it doesn't take that long. Many times, patient will come to me and say, Doc, I can't believe it. Somebody see me and they didn't know that I did major surgery or something like that, right? So in conclusion, are there any differences between fibroids and endometriosis, or say adenomyosis? And yes, the main differences is like in the pathological differences. We know what fibroids are, we know what endometriosis is or adenomyosis. There may be, in terms of clinical ambiguity when the patient present, because oftentimes they present with pain, chronic pelvic pain. And sometimes it's best to use the associated symptoms to actually say, ah, this may be endometriosis, this may be fibroids, to that effect, right? So for instance, pelvic pain of, of endometriosis, yes, pelvic pain of fibroid, they both do that, cause pelvic pain. They both cause severe period pain, dysmenorrhea. They both can cause dyspareunia, which is painful sexual intercourse. Heavy menstruation, heavy menstrual bleeding, intermenstrual bleeding, they both can cause infertility, fatigue, depression. We know endometriosis is more likely to cause painful urination, dyspareunia, whereas um, fibroids tend to cause frequency of urination, and endometriosis can cause painful defecation or even hematochezia or blood in the urine. So we can use our symptoms. Again, they both can cause constipation, obstipation, not both cause obstipation. Endometriosis is most likely to cause obstipation, that is not passing urine or passing flatus, right? May cause diarrhea as well. So that's my presentation, ladies and gentlemen. Are there any questions?
Thank you, Dr. Potter.
Good.
Wonderful presentation. And there are some questions that we have for you. First, I will start on the YouTube side. There is one question here coming in from NT, and she says someone has stage 4 endo and fibroids, but no surgery due to frozen uterus. For the past 2 years, she has been on Vicine tablets. Are there other solutions? Is Vicine, I'm not sure if I'm pronouncing that correctly, is Vicine a good medication? She is depressed.
I personally don't believe in Vicine. It's Vicine. Vicine is actually an antiprogesterone. Progesterone is one of the receptors that are present in in endometriosis as well. Not only estrogen, but progesterone and estrogen work together. And Vicine is one of those tablets that that it's expensive to mention. You have to be taking it every day. You have issues, hot flashes. You have issues with osteoporosis, taking it. My experience using it on patient is not effective. The injections, using for instance the gonadotropin releasing hormone GnRH and the LHRH are probably better courses. You give her that for about 6 months. And again, depending on the age of this patient with a frozen pelvis, needs a good surgeon, is going with the urologist as well as the bowel surgeon as well, have an idea that, yes, this is what we need to do. Go into the surgery, adequate blood supply, knowing that, look, this is going to take a long time. We have a lot of dissection to move to unfreeze the pelvis and make a decision. Are we going to be doing pelvic clearance to alleviate the pain? Oftentimes, I've used these injectables, the Electrum or gonadotropin releasing hormone and the luteinizing hormone releasing hormone agonist, and they somehow give you a little chance, a little window to do what you need to do in terms of surgery. But this has to be planned, as I mentioned earlier. It has to be a multidisciplinary approach. Get other people involved, the urologist, the general surgeon, the endoscopist to help along the way. Do your MRI to see where you can find planes for dissection. I know very well that the surgery is going to be difficult, but then provide her with surgery because the Vicine is costly. It's going to cost you more than the than using the injectable.
Okay, and for those who would be wondering, what is a frozen uterus?
Not a frozen uterus, a frozen pelvis actually. It's a nightmare. I remember I've told you that part of endometriosis is scar, and everything is so stuck together inside there. Bowel is stuck, bladder is stuck. There's nothing free that is moving around. Because normally that surface called the peritoneum is a shine surface that allows the organs to move freely on each other. Bowel can move, bladder not necessarily, but bladder can be extended or distended. You have the tubes can move, ovaries can move, but in that situation, all that there is that the endometriosis has frozen everything. Everything is now sticking to everything. Bowel is stuck to bowel in loops. Bowel may be stuck to uterus. Bowel may be stuck to bladder. Everything is stuck. So there's nothing moving, and there is significant pain associated with this condition. Right?
Okay.
Mm.
Next question is, are there any natural treatments for endometriosis? I was scheduled for surgery, but I would like to try natural remedies, if it's available. I have it really bad, and this is coming from NH.
That I can say. I'm not offy on any herbs that does anything. Anecdotally, people have tried um, people have tried changing their diets and become strict vegans. Anecdotally, I've heard that. I'm not so sure, and nothing scientific to say that it actually does work. If we were to randomize and double-blind individuals into groups and say, okay, you eat meat, you don't eat anything, just vegetarian food, and you're a strict vegetarian or a vegan, then if you have endometriosis, then it's going to improve. There's no such study. So I can't say if there's anything. I know, generally speaking, as I mentioned in my presentation, the best way to deal with endometriosis is actually surgical removal of the endometriosis. Because remember, endometriosis is associated with scarring. Even though you may say, for instance, you may even use your GnRH or your LHRH medications. What still remains? You may not have active endometriosis anymore. Or even say, for instance, you were to go into the menopause and the endometriosis is not necessarily very active. What happens? What happens if that were to happen? The scar still remains. Scar still remains. Another thing that is important that people may not understand is that yes, we do a surgery and we do castration. That is remove the ovaries because we think the ovaries are the body's greatest source of the estrogens that feed endometriotic deposit. But that's not true. If we look at the largest organ, one of the largest organ system in our body, yes, you have the skin. Just beneath the skin, you have fat. Most of the estrogen that our body produces actually comes from the fat. It is the adrenaline source of the pre-hormones such as DHEA or DHEAS and androstenedione dione that actually is converted to testosterone. Testosterone is converted to estradiol in fat. So even if we were to take out the ovaries, you still have a source of estrogen. That's the reason why some people, oh, we do castration, hysterectomy, and they still have an issue because the fat is still providing estrogen. Remember I said that obesity, estrogen dominance is one of the conditions. Fat or obesity causes estrogen dominance. So even though if we were to get something, all right, get some sort of food that reduces the endometriosis, because we're still producing the hormones, yes, we're still going to have active endometriosis. Because there are people who, even in their menopause, still have active endometriosis, as I mentioned, from the adrenal source, and not necessarily from the ovarian source, because the ovaries in the menopause stop working. That's the reason why I'll say as well that using these hormones, GnRH or LHRH, these hormones actually just work on the hypothalamic pituitary ovarian axis, but they leave out of the equation the adrenal component, the adrenal and the fat component. So you're still going to get issues. But despite all of this, there's still adhesions that are there that are contracting and are pressuring nerves and creating pain. So yes, you may use this, but you still have the things that are causing the pain. So you may need the surgery, either minimally invasive to break down the adhesion, lyse these adhesive bands, and create less pain as a consequence.
And with that, persons are also asking if these situations, the fibroids, the endometriosis, can they come back after the surgery?
Guess we're talking about I guess we're talking about well, I just mentioned in terms of the endometriosis component, that because most of the times you're focusing on the hypothalamic pituitary ovarian axis, and you may do a surgery and you see, remember in the part of the presentation that there are different types of endometriosis. You have brown, you have black, you have yellow, and then you have white endometriosis that you can't see at all. And all you see I mentioned about is like using a Brillo pad on on one of your best what do you call it, pots, and you see
Yes.
scratches on it or whatever, something like that. When you look at that shiny surface on the inside through a laparoscope, all you may see is a little scratch on it, and that is indicative of endometriosis. If you're not astute enough to know that that is the case, then you may miss it. So if you miss that, and I did a major surgery to deal with something else, then, or I may have done castration, removing the ovaries, but the adrenal component is causing that to occur. So that is for endometriosis. Now let's look at in terms of recurrence of fibroid, right? Yes, there is truth that there's recurrence of fibroid. Remember, in the pathology or the pathogenesis of a fibroid, it is a single muscle cell or smooth muscle cell that develops into a fibroid. So when I take out a fibroid or a myoma, right, I'm removing that fibroid. And as I mentioned to you, I feel around to make sure I get everything else. But what about the fibroid, the muscle cell that was adjacent to that? At the time when I went in, there was no issue with it. But guess what? The insults that caused the first one to occur is still there, right? Genetic insult is still there. So that fibroid may now undergo genetic changes, or that not fibroid, that muscle cell may now undergo genetic changes and become a fibroid cell and create a problem. So yes, there is recurrence. There's a recurrence rate. That's oftentimes why we say, okay, you're doing a myomectomy. Your plan is to give birth or something. We're doing it here. Hurry up and get it done, because there's a risk of recurrence of this occurring. Right?
All right. Still have a couple more questions here. One is saying, can this condition be fatal?
Fatal condition. Endometriosis is not directly fatal because it's a benign condition. It's infiltrative. Yes, it's infiltrative, but directly it is not. It can cause problems. Say, for instance, you have endometriosis. For instance, the person mentioned stage 4 endometriosis or deep endometriosis, right? And it goes in and causes bilateral occlusion of your ureters. That is the tube that brings urine from the kidney to the bladder. If those two tubes are obstructed and you can't pass urine, then what's the end of that? You may end up with urine kidney failure, and consequent to that, the whole deal with kidney failure. On the other hand, say for instance, you have a bowel issue and you start getting bowel obstruction from that, from endometriosis, then it is the bowel obstruction, if not dealt with properly, can cause bowel perforation or bowel gangrene and perforation and can cause abdominal sepsis, and that can be fatal. But endometriosis on a whole is not fatal itself directly. Fibroids is the same. Fibroids are a benign condition. I mentioned that there are fibroids. There's a condition called leiomyoma sarcoma, which is the malignant form of a fibroid. It's very rare. About 0.001% of all fibroids are leiomyoma sarcomas, and they behave badly when they occur. So that in itself can be fatal. So that kind of fibroid, which occurs very rarely, can be fatal.
Okay.
Right? Hmm.
Next one. When there is fluid in the endometriosis cavity, is that bad? And if it is, how bad can it be?
I am assuming when you say fluid in the endometrial cavity, you're actually referring to what we call an hematometria, where there is actually blood. But that's the only thing that can be inside there. Sometimes in infectious condition, you can get pus inside there. So you can have that. But majority of the time, it is blood that is inside there. You can get blood being inside there from a fibroid that is actually blocking the exit where the blood must exit at the time when you have your menstrual flow. So that can be residual blood that is there, right? That blood that remains there, yes, the uterus, believe it or not, doesn't want anything inside there. It does its very best to get everything out, even the product of conception, even a baby. At the beginning, for those who have been pregnant before, in the early parts of pregnancy, you get that cramping pain in the beginning of pregnancy because the uterus is trying to get rid of whatever is inside of it, right? So what will happen if you have fluid inside the uterus? You will get pain, that cramping pain, because the uterus is trying to expel or get rid of that, right? So generally speaking, blood inside the endometrial cavity is not something that is dangerous per se, if it's just blood. If it is pus that is there, that's a different situation. That can be dangerous because pus is associated with infection, and then infection can give rise to sepsis, and sepsis can be fatal, right? So from that perspective.
I have several questions. I don't think we'll be able to go through all of them tonight, Dr.
Sure.
Potter. There is another one that says, can fibromyalgia makes endometriosis symptoms worse naturally during your cycle?
Fibromyalgia is a totally different condition, right? From endometriosis. Fibromyalgia is just a condition where there is general pain all over the body. And anywhere you have fibrous tissue and muscles and anything, in terms of even skeletal muscles, the endometriosis is not a muscle issue. It is endometrial tissue that causes adhesion, right? Fibromyalgia is a condition where there's fibrous tissue associated with muscles, and this occurs all over your body. Generally, there's a pain. So if you're having fibromyalgia and endometriosis at the same time, yes. Pain all over my body plus pain in my pelvis, yes. It can make things worse. But there are two different conditions.
Here, Paulette is saying, I noticed that my stool has recently been coming out as pellets and beads, like both. Is this an indication I could be having fibroid issues?
I think what you need to do is not assume it is fibroid. You need colonoscopy to see exactly what the situation is. So let us not assume that it is fibroids or endometriosis that's doing that. There are other things that can cause that to occur, and it's important that you should have colonoscopy done. So you need to see a gastroenterologist to have book a colonoscopy and see what's happening.
Looking again, what are the more serious effects of untreated endometriosis other than infertility? And what is in the special solution you use during surgery?
That's a secret, a trade secret. Not even my assistant knows what is inside there. So I'm not going to divulge this now. So anyway, what's the first part of the question again?
Um, what are the more serious effects of untreated endometriosis other than infertility?
I would say pain. Pain, 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 and pain. But endometriosis, I remember once I was doing a surgery on a young lady. I think sometimes it's hard to tell, I must mention, I must confess this. Sometimes it's hard to tell what you're going in for. You think it's fibroids and you swear it's fibroids and you go in and it's endometriosis, right? I went in and I had a frozen pelvis, right? It was frozen, nothing moved. So the best thing was to reconsider what I'm doing. So I closed, did nothing, and closed, right? Just took off samples for histological diagnosis, sent to the lab to test to make sure it's endometriosis. Shortly afterwards, this lady started having shortness of breath and some other things. Did CT scan of the chest and whatever was having fluid inside there. Sent her to Chest Hospital. Did what do you call it? Thoracocentesis, where we aspirated some of the fluid from there. It was blood. When the tissue was tested, it was endometriosis in her lungs, right? So you have serious consequences of endometriosis, not only pelvic, remember I said it's not only pelvic endometriosis, through the theory, so-called coelomic spread, where stem cells that were actually supposed to end up in the uterus, end up, make a left turn somewhere and gone somewhere else, end up in the lung or in weird situation in the brain. So if it gets there and it's not activated, then you may end up with strokes or things like that. So those are probably you can think of theoretically the most serious consequences. That young lady I'm speaking of in terms of what had to be done with her, she had to do a thing called a pleurodesis. We had to, normally speaking, there is a potential space between your lungs and your chest cavity. And they had to actually freeze that potential space, obliterate the space so as to get rid of the endometriosis in that particular patient. So you can have problems that way.
Okay, so I think I'll call it there for the questions. So
Okay.
I'll just, the person to do the vote of thanks will come in afterwards. I'll just say to those of us who are online that pain is an indication that something is going on. And so as women, let us not bear it out. And let us not just sit and say that periods are meant to be painful, because that's what we're told when we're growing up. Expect pains with period. But sometimes it's an indication that something else is happening. So the best thing to do is to get professional help and to get checked and tested. Dr. Potter, thank you for your presentation. I'll hand you over back to Dr. Morrison, who will take on the person to do the rest of the program. Go ahead, Dr. Morrison.
Thank you very much, Lady Ashford. Thank you, Doctor. A mouthful, much more than a mouthful for us this evening. But we have a gem, one of our young ladies, Laurie Johnson from the Louis Stewart Church, who will come on at this time to give the vote of thanks. Laurie, it's over to you.
Good night, everyone.
Yes, good evening.
The absolute pleasure is mine this evening to extend a heartfelt gratitude to Dr. Trevor Brian Potter for such an excellent and thorough presentation on endometriosis and fibroids. I am sure that all of us here would have learned something new, and it will be beneficial not only to us but other women which we are familiar, because once we have good information, we have to share it. Again, on the behalf of the Northeast Jamaica Conference Women's Ministries, including the GEMS, we want to say thank you. Thank you for your time and your dedication for putting together and presenting such important information. We wish you nothing but the best in your future endeavors.
All right, sounds like that is
Thank
it.
you.
Okay, and Dr. Morrison, there are persons who are in the chat, both on YouTube and on the
Yes.
Zoom, that is asking, Dr. Potter, where can they find you?
Oh,
It is also
um,
shared.
a number again. Presently at the Andrews Memorial Hospital at the physician's office, as well as 876-843-16, I think 1672. I think that's a number, or 876-768-1303. Those are the
All
numbers.
right.
Repeat the contact, please.
Right. I have it's best to probably get me through this number. 876-786-1303.
Thank you.
All right.
All right, and somebody posted it in the chat right away. So let me thank you, Doctor, again. The thanks was already said, but beautiful presentation, excellent presentation. And so we really want to say thank you and look forward to more presentations like this. I hope that the advertisement this evening would have allowed some of our ladies to be talking to you so that we can be in good health. Want to thank all those who were on our Zoom platform or YouTube platform this afternoon for coming on. I saw on Zoom that we had up to 140. Miss Brown will tell me how much we had on YouTube. But we thank you all from wherever you came. And of course, it's worthy to mention that we had our men with us. So we were going to have to look at a presentation dealing with the prostate and something some other time. But we thank you very much for coming. This has been useful information. We can share it. You know, you can't share it like Dr. Potter, but you can tell somebody about Dr. Potter. Thank you very much again. Have a good night. Thank you, Lady Ashwell, for all of this and for all those who participated. Thank you, Miss Brown, for holding together the YouTube for us. Bless you,
Okay,
everyone. Have a good night.
there was, I think, one or two persons who were saying they came on late, so they missed the presentation. You can go over to there's a YouTube link that was shared in the chat. You can find it there on the Northeast Jamaica Conference YouTube page. For those who missed it, you can go back and look at the presentation.
Definitely, we will look at it again. Thank you so much. And I see the Andrews number coming up there. So there is no doubt that we will be able to locate Dr. Potter. Thank you all. Good evening. God bless you.